The direct ophthalmoscope will give the user a real and apparent image, which means that the image seen is the correct way up and not inverted. The instrument is designed to be held with the head of the ophthalmoscope fitted into the user's orbit. Ideally, the instrument would be held in, for example, the left hand and fitted into the left orbit of the operator, or in the right hand for the right orbit. With the ophthalmoscope light intensity set at an appropriate point, the patient can be looked at from arm's length with the light beam shining at the bridge of its nose. This should allow visualization of the tapetal light reflection from both eyes and also an assessment of the pupil size. Once this has been done, then distant direct ophthalmoscopy can be performed. The technique requires that from arm's length the observer looks through the ophthalmoscope on a setting of 0 diopters for a normally sighted person. Using the tapetal light reflection, the operator assesses whether there are any black opacities present within the visual axis. These may be located anywhere from the precorneal tear film through to the retina. Once a black opacity has been discovered, it's important to assess whether it moves within the visual axis as the examiner moves. When the examiner moves from left to right or up and down, if the opacity remains static, then it's within the plane of the pupil. However, if the opacity moves in the opposite direction to the examiner, then it is in front of the plane of the pupil. And if it moves in the same direction as the examiner, then it's behind the plane of the pupil. This technique can be used to help differentiate nuclear sclerosis from cataract, as the nuclear sclerosis will still have a clear tapetal light reflection despite the obvious grey appearance of the lens on focal illumination, whilst cataract will block some of the tapetal light reflection, resulting in a grey opacity. Close direct ophthalmoscopy is the other procedure that can be performed with the ophthalmoscope. In this technique, the observer sets the ophthalmoscope on 0 diopters and finds the tapetal light reflection. The observer then moves towards the patient until they are finally only a maximum of a couple of centimetres away from the corneal surface. At this point, the retina should be in focus. It may be necessary to alter the diopter setting in order to get the optic nerve head in focus. Alternatively, the ophthalmoscope can be placed in close proximity to the globe, and then the observer looks through it. Either way will work correctly. However, it is important to remember to use the examiner's right eye for the patient's right eye and the examiner's left eye for the patient's left eye. The direct ophthalmoscope may also be used to facilitate examination of the lens and cornea. With the ophthalmoscope preset on approximately +10 diopters, the examiner may move closer to the patient until the lens comes into focus. If the setting is altered to about 15 diopters, then the cornea can be focused on in a similar fashion.